This is the next video, which is about cluster headache. I'm David Koenig at the Royal College of General Practitioners, and I'm speaking with Peter Goadsby. Peter, cluster headache, probably your major interest, I guess. It's something that you're well known for. Not as common as migraine, only about 0.1% of the population, but a huge impact on those sufferers' lives.
Yes, an extraordinary condition. When I was doing my early research, I was struck by how dreadful the attacks were when we were trying to do neuropeptide studies on it 20 years ago. So I've been really interested. I mean, I've never met a cluster patient who's had a worse form of pain, and I've seen 1,000 of them. I find that it's extraordinary that there's a form of pain, a headache disorder, whose pain is worse than knifing and gunshot wounds and renal colic and giving birth and everything. I mean, it's a remarkable, horrible thing. And it happens several times a day.
Well, I must say, I've only seen, in my career, I've only seen two really significantly painful things. One is cluster headache, the other is a dissecting aortic aneurysm, which wasn't very nice. But I said that at a meeting, and a woman put her hand up and said, well, you haven't been in childbirth, which rather put me in my place. But there's been a paper recently, I believe, from female cluster sufferers, and childbirth is a doddle compared to a cluster headache.
Childbirth is a doddle compared to a cluster headache, yeah. Only and coming straight from those who suffer it.
One of the problems with cluster headache is it's not diagnosed. I mean, it used to take about 16 years for a diagnosis to be reached, and these people have been around, have their sinuses drilled out, their glaucoma checked, their teeth taken out. Yeah. And I think one of the problems is that it had these various nomenclatures. GPs get confused with cluster migraine and all these various... you cannot miss a cluster headache.
Yeah, it's pretty stereotypical, as you say, and as you say, I mean, we did a study a few years ago and looked into this, and the time to diagnosis has come down from about 19 years to about 3 years now, and on average it used to take, I think, 7 doctors to see the patient, and now it's down to 3, so that's a good thing. About 2/3 of the patients will have had some sort of dental work done, and about 1/3 have had some sinus work done. Now, it's pretty stereotypical. The clustering, so most of the patients, 90% of them, will have their attacks come in so-called bouts, where they'll get 1 or 2 or 3 attacks a day. That'll go on for a couple of weeks or months. It'll stop, and then they'll be perfectly well. When they're in an attack, they've got one-sided, really severe pain, usually around the eye, like someone's pulling it out or got a poker in there, and it'll be horrible. They'll have eye watering or redness. The nose can be running or blocked. You know, and in contrast to a migraineur who want to sit here and not move, cluster patient will be rocking, they'll be moving about, they'll be wailing, they might get up and bang their head against a wall, and none of that will be worse than having their attack. So when you look at a cluster patient doing this or banging their head against a wall, you compare that to a migraineur who's trying to hide under the table and stay out of the business. Well, it's chalk and cheese, isn't it?
And this happens a number of times in a day, much shorter than migraine 4 to 72 hours, cluster...
Yeah, typically an hour to 3 hours.
Yeah, and that will happen during a cluster period?
Yeah, during a cluster period, the period called a bout, that will happen 2-3 times a day. And very often at the same time, so the patient will be waken like an alarm clock at 2 o'clock in the morning, and bang, it goes off. It
does have this biochronicity about it, doesn't it?
Yes, it's extraordinary, and it comes on, the peak prevalence is around the 2 equinoxes. So I think there's some very interesting, fairly primitive mechanism, I suspect, involved that's to do with the light day-night exposure times.
So we're looking at a totally different pathophysiology from migraine, really, from that clinical picture.
And the brain imaging of migraine is very much about the brainstem, whereas when you look at functional imaging in cluster headache, the major change is in the region around the back of the hypothalamus, where not far from where the human circadian clock is. So everything is different about it, so to speak.
Right. What else might cluster headache be? There are a number of other autonomic headaches.
Yeah, they're put in a little group of headaches where they're called trigeminal, as in trigeminal pain, autonomic cephalalgias, and the autonomic stands for the eye watering and redness and nasal congestion, and there's a little collection of them. The closest one is one called paroxysmal hemicrania. There's another condition which is related called Sunct Suna, short-lasting unilateral neuralgiform headache attacks with conjunctival injection and tearing, and probably related to these is a condition called hemicrania continua, and the differential diagnosis is, I think, on one of our sheets.
Okay. Let's move on to treatment. If someone presents to their GP, hopefully they won't miss it. Except there is a bit of a crossover with migraine, isn't there? There was a paper recently which did show there is a bit of, you can get autonomic symptoms in migraine, you can get photophobia. So there could be a little bit of confusion there.
Yes, you can get, as you say, but I mean, if you had to highlight the big picture things, I mean, the first big picture thing is, what does the person do during the attack?
Yeah.
Do they get up and bang their head against the wall, or do they go lie down in the dark? 90% of cluster patients will bang their head against the wall. 90% of migraine patients go lie down in the dark. That's a pretty good, 90% for one question.
Yeah.
That's within the 10 minutes that you got.
Yeah.
You've got to get that out. Find out what they do,
yeah.
and that'll help you enormously in the differential diagnosis.
I think it's generally agreed that a new cluster presentation should be imaged. I mean, there is this concern about pituitary tumours, about 1% of cases. So we discussed imaging previously, but I guess anyone. Can that be relaxed with someone, say someone comes in and they've had this headache for the 16 years and it's the same features, would you still image them then?
Well, if you said, I would, because unfortunately I've seen episodic cluster headache in the way we're describing it present years later, have pituitary tumour, having had the problem for years. So I think that given it's a recurrent problem, given that they're likely to have attacks at different frequency or different intervals, more or less over their lifetime, one scan is not much over a person's lifetime.
Okay. Do they ever turn up things, those late scans, or do you see?
Well, yeah, they do. They'll turn up pituitary lesions, and some of them will turn up sphenoid. I recall a case of a sphenoid meningioma turning up after years of typical episodic cluster headache.
Okay. And treatment, fairly straightforward. Now, injectable Imigran is the gold standard, and they can keep having it. There's no they don't get resistant to it, they don't get side effects, they can have it once or twice a day for long periods of time.
The limit's 2 doses in 24 hours, that's largely a safety limit.
Yeah.
12 milligrams in 24 hours, and there is no time limit on that. So there's a very good study from the early development program that will show that there's no tachyphylaxis to the effect and no particular problem using it for a year. Now that's horrendous. I realise what I've just said about the budget, but I mean, put that down for 1 second. From a medical point of view, there is no reason not to use it.
And oral triptan's ineffective, but there is some evidence to suggest that nasal zolmitriptan particularly is useful, can be useful.
Nasal zolmitriptan has 2 placebo-controlled trials, and nasal sumatriptan 1 placebo-controlled trial. So there's a good evidence base. There's a European license, I think, for nasal zolmitriptan in cluster headache. So pretty good evidence, safe ground. And of course, oxygen,
which has recently had a randomised controlled trial which fortunately, because otherwise it would have been a bit difficult telling everyone it's been a placebo effect, but that actually has been shown to be beneficial. It's got to be 100%. And until recently, I think from the general practice perspective, it's only been recently that we can actually prescribe 100%. And in the past, everyone probably got about 35%. And now on the home oxygen form, if you put cluster headache, 100% oxygen, in fact, you can actually download a filled-in form from the Cluster Headache Society website. 100%, it's got to be 100% oxygen. Yeah,
the study you're referring to, 76 patients, 278 attacks, randomised, placebo-controlled against air. Each patient did 4 attacks in a crossover, 22% response to air, 78% response to oxygen. Crystal clear, at 15 minutes.
Right.
So it's nearly 4 times more likely to produce an effect than the air at 15 minutes. The great advantage is some patients with cluster headache will have 3 or 4 attacks in a day, and you can only use sumatriptan on 2 attacks.
Yeah.
So it's a clear evidence base, it's safe, it's the right thing to do.
And of course, my favourite medication is steroids.
Yes. Great for short-term, if the bouts are short. Because what tends to happen is that when the steroid dose comes down, the attacks come back. So if you're using it for 3 or 4 weeks and the bout's only 5 weeks, that's great. If the bout is 3 months, then you're buying yourself some time, but you better have a strategy when your steroids come.
And if the attacks, looking at preventative medication now, because about 10% of sufferers will get chronic cluster headache. These poor guys will get must be terrible.
Yes.
Verapamil treatment of choice, got to be high doses. Yes. It's important to monitor ECGs as well.
Yes.
But
very important.
Say someone has 3 months episodes. Is it worth trying to ramp them up on verapamil for that 3-month period?
It depends on the individual. If you're a person who's got 1 attack a day, it's at 2 o'clock in the morning, you respond in 10 minutes to oxygen, you've got the bottle sitting there Why would you want to take anything else? Why would you want to muck your body physiology up more? You might be happy with that.
Yeah.
You might take one sumatriptan injection a day. If you don't get any side effects and you go back to sleep in 10 minutes, well, that's okay. Compare that to the person who's got 5 attacks a day. They can't take sumatriptan for all of them. Oxygen, 2 of them are happening during the day or 3 during the day while they're at work. They can't lug the bottle around so easily at the moment. That needs better development. They may want to be on preventive. So I think it's a very much, like most things that we've been talking about, it's very much, show me the disorder in the context of the patient, and the treatment can be quite
different. Can you build up verapamil that quickly to get them up in a 4-week period to a reasonable therapeutic
dose? What you do
dose?
is you build it up slowly with in 2-week intervals on the first bout, and you might not quite get there. It mightn't be adequate. It's going to be a bit slow the first bout, but on the second bout, you know what the indicated dose is, so you go straight into it. You get a baseline ECG, you get straight into it, and then you just need to check the ECG 2 weeks later. So the first bout may be a bit rocky, but this person will be back in a year with another bout, and in a year with another bout, and in a year with another bout. So then you know what the dose is, you go straight at it.
And just keep on monitoring ECG as the takeaway message.
Yes.
If verapamil doesn't
looking
work,
for the PR interval. The verapamil prolongs the PR interval. Once it gets over 0.2, they start to pretty quickly get into problems with heart block, and it occurs in about 20% of cluster patients. Right. Verapamil.
Other options: topiramate, lithium.
Lithium's the classic option. Measure the blood levels, get them upright. Topiramate has quite a few open label reports, and probably it's effective. Melatonin is used as an adjunct, perfectly safe and easy to use thing that's made in this area in the brain. So.
And methyl-sergide, and occipital nerve injections are being increasingly used as well.
Exactly.
And if all else fails, then surgical intervention is not an uncommon.
Well, if all else fails in chronic cluster headache, the surgical side is quite altered in the last 15 years. It used to be thermocoagulation of the trigeminal ganglion or trigeminal root sections, and that's more or less stopped. I think the treatment of choice for medically intractable chronic cluster headache is now occipital nerve stimulation, and for those who don't respond to that, we even have deep brain stimulation in the area that we identified in the back of the hypothalamus. So there's really it really would be quite exceptional to find a patient with cluster headache for which there's nothing that can be done.
Okay, well, on that positive note, we'll finish there. I think the important takeaway message is cluster headache, don't miss it, which is the important one. Thank you, Peter.
Thank you.